No, it's okay. It's okay. Thank you. A very good morning to all of you. First of all, I would like to thank Professor Vitull Gupta and his entire team of this MAPICON for giving me this opportunity. So my topic is today clinical approach to diabetic foot in a primary healthcare setting. Professor Gupta rightly said, though it's a very important but it's a neglected subject in our day-to-day clinical practice. So if you look upon the overview and the magnitude of the problem, among patients with diabetes, 15% develop a foot ulcer, and among them about 12 to 24% require non-traumatic amputation. Diabetic neuropathy usually tends to occur 10 years after the onset of the disease, which leads to foot deformity, ulceration in the later course of the disease. All diabetic patients have an increased risk to develop foot infection and ulceration. Thereafter, repeated trauma leads to collapse of the midfoot, which is also known as Charcot neuroarthropathy. Every 20 seconds, a foot is lost due to complication of diabetes globally. Diabetic foot infection usually superficial, may be a little bit a small ulceration at the beginning, which can be easily overlooked by a clinician. And diabetic foot lesions are responsible for more hospitalization than any other complication of diabetes, and it has higher mortality than many cancers. Now the risk of the ulcer of amputation is increased 2 to 4 fold with the age as well as the duration of the diabetes. As the age advances, as the duration of the diabetes increase, the complications and the chances, the prevalence are more, like poor glycemic control, peripheral neuropathy, cigarette smoking, foot deformities, pre-ulcerative callus, corns, peripheral artery disease, and of course, previous history of foot ulcer. Even after successful management, the recurrence rate is about 66% and the amputation rate may rises up to 12%. Visual impairment, CKD, etc. So why do you perform a foot assessment? To identify foot at risk. Remember, whenever a patient comes to your clinic, from the day one, he is diagnosed as a diabetes, his or her foot is at risk of developing infection from the day one itself. So to prevent foot ulceration, gangrene, amputation, and to assist the maintenance of mobility, independence, and healthy, active lifestyle. Regarding etiopathogenesis, it must be determined before deciding the treatment plan. Multifactorial causes of ulcerations like osteolysis related fractures, dislocation, deformities, repetitive trauma, improper foot loading, microtrauma, metabolic abnormalities of the bone, etc. all leads to diabetic foot. In most patients, peripheral neuropathy, peripheral arterial disease, or sometimes both may play a major role. Therefore, commonly classified as neuropathic, ischemic, and neuroischemic. So, early detection and appropriate management can prevent this type of these complications. And this is a problem triad: neuropathy, ischemia, deformity, always associated with infection. Now, the clinical features three, like neuropathic, ischemic ulcer, and neuroischemic ulcer. Sensation wise, if you see, there is a sensory loss in neuropathic ulcer. In the ischemic, usually is painful, and there is some degree of loss of sensation in case of neuroischemic ulcer. Wound bed pink and granulating, surrounded by callus in case of neuropathic ulcer. In ischemic ulcer, plain and sloughy with poor granulation. Foot temperature and pulse is very important. Warm with bounding pulses we see in neuropathic ulcer. In case of ischemic ulcer, cool with absent pulses because of peripheral arterial disease. Location is also very important, as you see in the picture. The weight bearing areas of the foot, such as metatarsal heads, heel, and over the dorsum of the claws, toes in case of neuropathic. In case of ischemic, tips of the toes, nail edges in between the toes and the lateral borders of the foot. And in case of neuroischemic, margins of the foot and toes are usually affected. Prevalence wise, neuropathic ulcer are mostly common. It's about 46.1% prevalent in India. So diabetic foot examination is the cornerstone of diabetic foot health. This is a very important test, a gait balance. While judging a gait of a patient in your clinic, you can assess the foot. You can assess, you can anticipate, you can diagnose a foot problem hidden inside. So this is the timed up and go test, very reliable. Patient arise from a chair with their using arm, walk 3 meters, turn and return to their chair and sit down. They are allowed to use their own walking aids. If it less than 10 seconds, normal. If it is more than 14, abnormal. If it is more than 20 seconds, severe gait impairment. So in that case, you look carefully, examine carefully the foot of the patient. Musculoskeletal examination, like look for the range, strength of the motion, look for the different kind of deformities we come across in the clinic. Bunion, Charcot changes, hammer toe, pes cavus, claw toe, pes planus, hallux valgus, etc. Neurological examination, 5 simple tests: 10 gram monofilament, 128 Hz tuning fork, ankle reflex, pin prick, bathymetry if you have a this tool, and tactile sensation. 10 gram monofilament test, I am not going in details. In a study, it has been seen that loss of sensation of simple this 10 gram monofilament was associated with 10-fold risk of foot ulceration and a 17-fold risk of amputation over a 32-month follow-up period. There are 6 sites at which the monofilament is touched and assessed. This is another very useful tool. If you don't have monofilament, this is a very useful tool, and specificity, sensitivity wise, it's at par to the monofilament. Ask the patient to close his or her eyes during the test. Test is performed by touching the tip of the first, third and the fifth toes. Very gentle. If they don't feel, do not to repeat. Register yes, that is sensory loss, if the patient does not have a sensory response in more than 2 toes. In one limb patient, if there is no sensory response in more than 1 toe, it is considered to be yes, that means sensory loss. In vascular assessment, look for the absent weak pulse, mottling, dusky color of the skin, cold foot, shiny with dry skin, atrophic nails, loss of hairs in lower limb. Taking temperature is also very important by the infrared thermometer, very ordinary tool. Palpate the pulses, dorsal speed, posterior tibial, it's of utmost importance. Check the ABI if you have a peripheral Doppler. Normal index is 0.9 to 1.2. If it is between 0.6 to 0.9, risk of ulceration is moderate. And if it is less than 0.6, severe vascular disease and there is a chances of developing foot ulcer. Check the Doe brachial index, that is if you have that cuff 0.5, then it's peripheral vascular disease. Dermatological assessment, look for callus, ulcer and with the size, periphery, depth, adjacent skin environments, etc. Swelling, redness, warmth, tenderness or pain which can be absent in peripheral neuropathy. Take a note of the slow, necrotic gangrenous tissue, foul odor, look for the dry exposed tendon, ligaments, fascia, etc. Look for the sinus tract, that is the evidence of osteomyelitis, evidence of abscess, and look for the ulcer base, necrotic, it's black, yellow means slow, pink means ulcer is healthy, the granulation tissue is coming up. Diagnosis of osteomyelitis, usually there is a sausage-like appearance of the toe. Probe to bone test, the clinical testing with the help of the blunt probe. When you introduce, you have that gritty feeling. And of course, X-ray. There's a plain radiograph. If you have any suspicion, go for a plain radiograph. It will tell you the diagnosis of osteomyelitis. And MRI, CT, this is the other modality, usually not done in the primary healthcare setting. Now, this is a very important part, which is often and regularly ignored. Examination of the footwear. Insist on removal of the shoes and the socks. Inspect footwear from all sides. Look for shoes that are worn out, too small, too narrow, toe box too low, have high heels. Inspect socks also. There's staging, Wagner's classification, one of the validated staging, grade 0 to grade 4 till grade 3. It is reversible if it is managed properly and timely. Beyond that, if one gangrene sets in, amputation is inevitable. MAT test, it detects high pressure points, arches of the foot, Charcot foot, etc. If you have this facility, it will be help you to evaluate the proper footwear, offloading footwear. Biothesimeter, vibrometer. If you don't have a biothesimeter, at least this vibrometer, the smaller one, can give you idea about the vibration perception threshold. Handheld Doppler, if you have, it's a very useful tool. Non-invasive vascular assessment utilized for diagnosis for monitoring of peripheral arterial disease. It is the ratio of the highest systolic blood pressure at the ankle, that is dorsalis pedis, as well as posterior tibial artery, to the systolic blood pressure at the arm by handheld Doppler. These are the other modalities like duplex scan and other acute transcutaneous oxygen measurement not usually done in the primary healthcare center. Laboratory investigation wise, glycemia, fasting sugar, PP sugar, A1C, CGMS, infection wise, hemoglobin, CBC, procalcitonin, ESR, culture, etc. and systemic investigation by LFT, RFT, lipid profile, retinal examination, ECG, etc. Now, this is a very important slide. Risk categorization. The frequency of follow-up, 0. Category 0, no sensory neuropathy, once a year. Sensory neuropathy, once in every 6 months. Sensory neuropathy and signs of peripheral vascular disease or foot deformities, then once in every 3 months. If there is any history of previous ulceration or amputation, I personally feel every month. Good wound care treatment is largely determined by offloading, debridement, moist dressing, control of infection. These 4. Excuse me. So, tight blood glucose control and achieving A1C target to the guideline is mandatory throughout the course of the disease. Now, offloading, meaning avoidance of all mechanical stress on the injured extremity while maintaining the necessary ambulation. Why necessary ambulation? Usually these patients come from the very low socioeconomic strata, and आप अगर पैर ही उसको कर दोगे तो बेचारा खा कमाएगा क्या? So purposes: preventing pressure ulcers, promote healing by redistributing weight. Offloading devices reduces trauma to the ulcerated area, allowing to the heal. Gold standard is TCC, that is total contact cast. It is considered for the best for treating the plantar ulcer. It distributes pressure evenly over the entire plantar surface of the foot. But there are some contraindications like infected diabetic foot ulcer or osteomyelitis, because the wound cannot be inspected on the regular basis. In this patient, other modalities are Scotch guard boots, healing sandals, crutches, walkers, and even wheelchairs also can be given. So proper footwear is a mandatory for primary as well as secondary prevention of diabetic foot ulcer. Now, debridement, a removal of the necrotic and senescent tissue as well as the foreign and infected material from the wound. It is mandatory. Sharp debridement is essential for management of the foot ulcer. Now, there are different kinds of dressing, different kinds of guideline, but remember the ideal dressing feature should be to remove excess of exudate and toxic component, to maintain high humidity in the wound, to allow gaseous exchange, to provide thermal insulation, to provide protection from secondary infection, to allow removal of dressing without traumatizing the healthy granulation tissue, and dressing material should be free from particulate and toxic components, and it should not be associated with less pain. Control of infection. Infection in diabetic foot is limb threatening sometimes. Superficial infection usually caused by gram positive, and deep infection usually is polymicrobial. Surgical debridement is essential in acute deep infection, osteomyelitis. Empirical therapy sometimes often started before culture results are available. Choices may be coamoxiclav, clindamycin, linezolid, sometimes injectables also. But once that the culture and sensitivity report are obtained, appropriate antibiotics to be started. And topical antibiotics sometimes can be used in case of milder infection. And duration of therapy may be 1 to 2 weeks in the milder infection. In case of osteomyelitis and more severe infection, it may prolong up to 6 weeks or more. So treatment modalities would be microbiological control, wound control, vascular control, mechanical control by offloading, metabolic control of hyperglycemia, and of course health education, that is educational control. Now, amputation should not be considered unless a detailed vascular assessment has been performed by a vascular staff. Indications are ischemic rest pain that cannot be managed by analgesia or revascularization, a life-threatening foot infection that cannot be managed by other measures, and non-healing ulcer cannot be managed with conservative management. In these circumstances, you should go for amputation. Otherwise, please reevaluate before going for such a drastic step to a patient. So early warning signs in order to identify the foot at risk and timely refer to the tertiary center. Swelling of the foot or ankle, very cold feet or legs, color changes red, blue, black, discoloration, pain in the legs or while walking, A patient with acute limb ischemia is characterized by 6 P's: pulselessness, pain, pallor, perishing cold, paresthesia, and paralysis. This poses a clinical emergency if not managed timely and effectively. Tachycardia, hypotension, like hemodynamic instability, open sores, non-healing wounds, ingrowing toenails, loss of hair in leg and feet. So take home message would be this condition, this diabetic foot complications are totally preventable. Remember, totally preventable. So proper patient education, good glycemic control, regular foot assessment including vascular stuff and neurological assessment, removal of chronic pressure by offloading whenever necessary. Diabetic foot ulcer need multidisciplinary approach. Multidisciplinary foot care team should be acted upon. Thank you for your patient sharing. Thanks, sir.